ARHP. I will be moderating this webinar. Before we begin, I'm just going to make a few housekeeping announcements. If you called in using a phone and you get disconnected, please dial back into the number listed in your GoToWebinar registration email. If you have immediate questions regarding the webinar technology, please type them into the chat box on your screen. There will be a question and answer session at the end of the presentation, and we look forward to answering your content-related questions at that time. 1 hour after the webinar, you'll receive an email from GoToWebinar with a link to the PostTest Survey. Your continuing education certificate will be generated upon completion of this survey. In 6 weeks, you'll receive a follow-up assessment to gauge how you've integrated competencies into your practice. Finally, please note that the session is being recorded. The recording will be soon available to view on demand on the On Demand Webinar section of ARHP's website. At this time, I'd like to introduce Amna Dermish, today's presenter. We're really thrilled that she could join us today. Amna Dermish is a board-certified OBGYN with Planned Parenthood of Greater Texas. She attended medical school at the University of Colorado and completed her residency in obstetrics and gynecology at Pennsylvania Hospital in Philadelphia. Following her interest in increasing access to full reproductive health services, she completed a fellowship in family planning at the University of Utah. Her primary fellowship research interest was in increasing access to IUDs through improved clinician training. She continues to seek out ways to remove barriers to the most effective methods of contraception through education and outreach to women and their healthcare providers. Amna, you have the floor.
Thanks, Priya, and thank you everyone for joining today's webinar. Let's see, do I take control here? So I'm sorry, a little to advance the slide. Do I have control of the screen now?
Yes.
Okay. Okay, there we go. Great. So I'm going to start with just an acknowledgement of the support that we received. This program was made possible today through educational grants that we've received from activists, Bayer Healthcare Pharmaceuticals, and Merck & Company, as well as the National Campaign to Prevent Teen and Unplanned Pregnancy. In terms of disclosures, you can see the disclosures for all the people who were involved in putting together these slides. Personally, I am a Merck Nexplanon trainer as well as a Liletta trainer for activists. All right, so the learning objectives for this talk, I hope by the end of this session that participants would be able to explain the differences between the 4 types of intrauterine contraception that are currently available in the United States, be able to select appropriate candidates for IUD insertion, and then to describe 2 possible side effects for each type of intrauterine contraceptive. We're going to start with an introduction, go on to a didactic lecture that includes case studies, and then we'll have time for Q&A, and we'll also provide you with some additional resources and a summary in closing. So a little background information first. I think it's always important when you're talking about contraception to talk about unintended pregnancy, which is a huge public health issue here in the United States. The data on this slide are from the National Survey of Family Growth, and this is pretty new data from 2011 that was just published a couple months ago in the New England Journal. And we actually have good news where for the first time in many years we're actually seeing a reduction in unintended pregnancies. 45% of unintended pregnancies in the United States are unintended, which is down from 51% as of 2008, and it's the first decline that we've seen in decades. So that's a huge public health victory, and a lot of that decrease in unintended pregnancy rates are actually thought to be due to an increase in use of the most effective methods of contraception, including the long-acting reversible contraceptives such as IUDs and implants. Of those unintended pregnancies, A little over a quarter are characterized as mistimed, meaning the woman wanted to get pregnant at some time in the future, but not now. And about 20% are unwanted, meaning the woman was never planning to get pregnant. About 40% of unintended pregnancies do result in abortion. And the other 60% are either in live birth or in miscarriage. So we do know that despite the overall reduction in unintended pregnancies, there are still huge health disparities that remain. So women who live at below 200% of the federal poverty limit, minority women, women who lack a college education, all have much higher rates of unintended pregnancies compared to other populations. So it still remains a big issue, though again, we are starting to make strides in the right direction. All right, so now that we have that background, we're going to go on to talk about the current IUC methods that are available in the United States. A little terminology to start off with. You'll see these terms used throughout the talk: IUC, IUD, and IUS. IUC stands for intrauterine contraceptive, and IUD, intrauterine device, and those terms are used interchangeably. IUS stands for intrauterine system, which is used primarily to refer to the levonorgestrel IUDs, such as Mirena, Skyla, or Liletta. And Paragard is often referred to as an intrauterine device or IUD. All right, so let's start with the first poll. True or false, IUDs need to be removed for PID treatment? So we'll give you guys about 30 seconds here to enter in your selections. All right, so we have the results here. 96% of you reported that this is false and 4% true. So this is great. Makes me very happy to see that you guys are in fact right in the majority. IUDs do not need to be removed if a woman presents with PID. You can treat with the IUD in place, and only in situations where she didn't respond to that treatment would you remove the IUD. So okay, so let's, sorry, I skipped a page there. So let's go on to dispelling some myths about the IUC. That's a great question that sort of leads to this next slide. So here, there are some of the facts and fictions about IUDs. Common one we hear is that IUDs are abortifacients. IUDs are not abortifacients. The definition of a pregnancy is the state that occurs when a blastocyst implants in the uterus. IUDs are not able to disrupt an implanted pregnancy. Their primary mechanism of action is preventing fertilization, and that's true for all methods of IUDs. They also do not cause ectopic pregnancies. In fact, it decreases the risk of ectopic pregnancy simply by being such an effective method of contraception. However, if a woman does get pregnant with an IUD in place, there is a high risk of it being an ectopic pregnancy. So though their overall risk of pregnancy is reduced, the risk of that pregnancy occurring, if it did happen, is higher that it's ectopic. It does not cause pelvic infections, and that's one of those tough myths that still persists. In fact, surveys of OBGYN show that even though people do have more positive attitudes towards IUCs, a lot of people still hold on to this myth that there is an increased risk of pelvic infection in women who have IUDs. And that is not true. It's really the existence of a sexually transmitted infection like gonorrhea or chlamydia that increases that risk, not the IUD itself. And we'll talk about that a little bit further on. It also does not affect future fertility. And there's been a lot of good studies that have shown that IUD use is not associated with infertility. They're not large, they're quite small. They measure about 3 centimeters in size, and I think this is an important one to address with patients. They might have misconceptions about the size of the device. So it's always helpful to have the little models in your clinic so you can actually show women how small the IUD is and how it can fit very easily in the palm of their hand. Another safety issue, nulliparous women, and that's another one that we definitely still see hanging around as a myth. Again, reams of data showing that IUDs are safe to be used in nulliparous women. The failure rates and expulsion rates are actually lower for nulliparous women than for parous women, which is great. So along the lines of the ectopic pregnancy, a history of a prior ectopic pregnancy is not a contraindication to IUD use. They do not need to be removed for PID treatment like we addressed in the last slide. If a woman does develop an infection, you treat with the IUD in place and only remove if there's no response to treatment. And then finally, you do not have to remove the IUD if there are any inflammatory changes noted on a PAP. Sometimes you might get a PAP test that reports actinomyces-like organisms, and those can normally exist in the female genital tract, are not indications for removal. If they're symptomatic, however, you should treat them and remove it. All right, so let's talk about the individual types of IUCs that are currently available in the United States. First off, the copper T380A IUD, which is currently marketed as Paragard by Teva Women's Health. This is a T-shaped device made out of polyethylene with copper wrapped around it. It's 36 millimeters long and 36 millimeters wide. And the insertion tube measures just about 4.5 millimeters in diameter, so very small. It's FDA approved for 10 years of use, but there's good data showing that it works for at least 12 years. And it's the only highly effective, completely non-hormonal method of contraception. And actually also the most effective method of emergency contraception available in the United States. I keep skipping these slides. So as a method of EC, the copper IUD is nearly 100% effective. There was a review of 42 studies which showed a failure rate of 0.09%. So about 99.1% effective at preventing pregnancy after unprotected intercourse, which compares to about 85% overall effectiveness for the emergency contraceptive pills. And it can be inserted up to 5 days after unprotected intercourse. And it's a great option for women who are overweight or obese, which is we know is a reason for decreased effectiveness in some populations for the emergency contraceptive pills. Another thing that oftentimes gets overlooked when talking about emergency contraception is future acts of unprotected intercourse. So even if your EC is going to be effective for that single act, it's really only the copper IUD that's going to continue to provide protection after that episode of unprotected intercourse. And no additional backup is needed. And so I think, it's always important when we're having the conversation about emergency contraception, even though it's a lot easier to hand off a pill, patients I think really deserve to know the difference in effectiveness with a copper IUD, and in a lot of situations it may be the best option for them. All right, now the levonorgestrel IUD, or IUS as it's often referred to, we have two types of 52 milligram intrauterine systems and then an additional 13.5 milligram IUS. The two 52 milligrams are the Mirena and Liletta. Mirena is manufactured by Bayer Healthcare Pharmaceuticals, Liletta by Actavis. Mirena is currently approved for 5 years. Although there is data demonstrating efficacy up to 7 years. It's been available here in the United States since the year 2000, although it's been used in Europe since 1990. And it releases the levonorgestrel at a rate of about 20 micrograms per day, decreasing to about half that amount over its lifetime. The Mirena IUD is a little bit smaller than the Paragard. It measures 32 millimeters by 32 millimeters compared to the 36 millimeters of the copper IUD. The Liletta has a release of 18.6 micrograms per day, which also decreases to about half that amount over its lifetime. It's currently approved for 3 years of use, And the reason for that, you might ask yourself, well, if it's the same dose as the Mirena, shouldn't it also be good for 5 years? Well, the manufacturers of Liletta were trying to get it released onto the market as soon as possible, and so they did release it after they had their initial 3-year data, and they are planning to extend the approval life once the data is achieved at 5 and 7 years. It measures the same as the Mirena at 32 millimeters by 32 millimeters and has been available here in the U.S. since 2015 when it was approved by the FDA. The great thing about the Liletta is that it's also manufactured through a nonprofit pharmaceutical company, Medicines 360, who had the goal of increasing access to the most effective methods for women who couldn't afford the IUD. Traditionally, these are the most expensive methods of contraception, and so for clinics who can participate in the federal 340B drug pricing programs, they can purchase the Liletta IUD at a significant discount. In terms of side effects of the levonorgestrel IUDs, during the first 3 to 6 months of use, it's common to have irregular bleeding and an increase in the number of bleeding or spotting days from baseline. However, after that period of time, bleeding will decrease in most women, so that the amenorrhea rate can be as high as 50% after 1 year. Compared to the copper IUD, where the most common side effect is an increase in bleeding, although that usually in most women will only persist for the first 6 months of use. Possible complications of insertion are perforation, infection, and expulsion. The final IUD that's available here in the U.S. is the 13.5 milligram intrauterine system. So this is the levonorgestrel also. Marketed as Skyla, with a release of about 14 micrograms per day of levonorgestrel. As you can see, that's lower than the 52 milligrams, which have about a 20 microgram per day release. It's approved for 3 years, and given the lower dose of levonorgestrel, the amenorrhea rate tends to be lower with the Skyla compared to the Mirena or the Liletta. It does contain a silver ring, which you can see on the screen just at the very base of the T-arms, and that helps distinguish it from the levonorgestrel IUS, the Mirena on X-ray or ultrasound. Skyla was developed and marketed to help appeal to younger nulliparous women. It is smaller in size, 28 by 30 millimeters, again compared to the 32 by 32 for the 52 milligram IUSs and the 36 by 36 for the copper IUS. So how do IUDs work? The mechanism of action differs based on the type of IUD that we're talking about. So for the copper IUD, the exact mechanism of action is not completely clear. However, the evidence that we have does suggest that the main way it works is by preventing fertilization. It is toxic to sperm and appears to be toxic to oocytes as well. It reduces sperm motility and viability and prevents them from fertilizing the oocyte. There is some theoretical possibility that it may prevent implantation of a fertilized ovum, which would explain partially the high effectiveness of the copper IUD when used for emergency contraception. It has been shown in some studies in vitro in the lab to be toxic to a fertilized ovum, although again that's never been demonstrated in vivo. For the levonorgestrel IUDs, the mechanism of action is similar to other progesterone-only methods of contraception, and that's primarily through thickening of the cervical mucus and inhibition of sperm motility and function. The progesterone does cause endometrial atrophy, which is the reason for the decrease in menstrual flow. It's possible this may also have some contraceptive action, though again, if any, it would be a secondary or tertiary effect. And this can certainly be a concern to some patients who are worried about prevention of implantation as a method of contraception. But any of those post-fertilization effects are theoretical and haven't been proven, and it's really the pre-fertilization effects that are the primary methods of action for these methods. All right, how effective are IUDs? So this is a chart here of first-year failure rates based on typical use of various methods of contraception. And you can see that the IUDs and implants are at the very bottom of the chart, along with female sterilization in terms of effectiveness, although of course the IUDs are 100% reversible. The failure rate for the leave-in egesterol IUS is 0.2% for and that's for the Mirena, the 52 milligram. For the leave-in egesterol 13.5 milligram, which is the Skyla, the failure rate is slightly higher. It's 0.4%, although of course still way lower than any of the other shorter-acting reversible methods. The copper IUD does have a slightly higher failure rate than the other types of IUD at 0.8%. And again, comparing it to the effectiveness of sterilization, really just right on par with that overall, which is, again, a huge advantage for a lot of women, and some people even characterize the IUDs as a form of reversible sterilization. So what are continuation rates for IUDs? They're, in fact, quite high. 70% continuation rate at 3 years for all IUD users. And this is data from the CHOICE project, which was a study of over 9,000 women aged 14 to 45 who were had the opportunity to have any method of contraception at no cost for 3 years. And so when cost was removed as a barrier, they actually saw a very high uptake of Lark, where 3/4 of women who enrolled in the study ended up choosing either an IUD or an implant as their method of contraception. And again, 3-year continuation rates quite high at 70% compared to women who didn't use the Lark method, who had 3-year continuation rates of only 30%. All right, so let's talk about, now that you have all that great background information on IUDs, how do you actually determine who's eligible for an IUD, and how do you talk to them about that method? We'll start with a case presentation. So here we have Tara, 17-year-old G0, who's brought in by her mother saying she is, quote, bad at taking pills and wants something different. She has a history of PID 2 years ago. So I want you to start thinking here, what would your clinic or office do for a patient like this? How would you counsel her, and what are the main issues that you need to think about with this patient? All right, so we're going to move on to our second poll question. This is a pretty straightforward one. Is Tara a good candidate for an IUD? Yes, no, or not sure. You can go ahead and select your answers. We'll give you guys about 30 seconds here. Okay. All right, so we have our results, and we had 83% who said yes. Nobody said no, that she was not a good candidate, and 17% said not sure. So it's great. You know, Tara is actually a good candidate for an IUD, so the vast majority of you guys got this question right, and I really appreciate the 17% saying not sure. And that's, you know, again, great, because that's the whole point of this webinar, so that by the end of it, you should walk away with more certainty as to who is a good candidate. So let's talk about her a little bit. What are some of the red flags in here that might make you consider whether or not she is a good candidate for an IUD? First, we'll start with her history of pelvic inflammatory disease. So as we did talk about earlier in this slideshow, we know that concurrent PID is not indication for removal of an IUD. So if she were to develop PID with the IUD in place, you wouldn't need to remove it. But what if she has a history of it? In fact, a history of PID is not a contraindication for IUD use. What you would want to do is make sure you screen her for STIs. She certainly has risk factors for future STIs, having had PID in the past. So you would want to make sure that you counseled her, screened her appropriately. And in these patients, it's really important to emphasize the fact that even though she is a good candidate for an IUD is not going to protect her against sexually transmitted infections. And so dual method use with condoms for protection about STIs is really important. In fact, there have been some studies that show that women who use the more effective methods of contraception, IUDs, implants, and depot, patch, and ring are less likely to use condoms for protection against STIs than women who use pills alone. And the thought is that that sense of security, it's not a false sense, it's a true security in having a more effective method. They're less likely to use condoms as a backup protection against pregnancy. However, when they don't use that backup, they're losing that extra protection against sexually transmitted infections. So again, always important to counsel your patients appropriately so that they're aware that they need to continue to use condoms for STI protection. Another concern here in this patient is who is actually wanting the method of contraception or the IUD. Is it the mother, or is it Tara, or is it her partner? And it's always important, particularly with teenagers, to get a history with your patient alone without any other people in the room and have a discussion and make sure that they're making this decision of their own accord and not being coerced, and that they think this is the right method for them. The fact that she's adolescent or nulliparous are both not contraindications to IUD use, and in fact, the American Academy of Pediatrics now recommends that Lark be a first-line method of contraception offered to all teens. We discussed STI screening, confidentiality. Again, that's important. It goes back to getting the Tara alone without her mother or her partner in the room to talk to her about her options and making sure that she's assured of confidentiality. We'll talk about the one key question here in just a minute. And then, another issue that may affect your ability to offer her is what kind of Larks are available in your clinic. So we're going to talk about the CDC medical eligibility criteria as a way to help screen your patients to determine whether or not they're good candidates for IUC use. Now, I'm sure at least some of you are familiar with the medical eligibility criteria that were put out by the CDC, which gives you guidelines on what contraindications are to different methods of contraception use. They were put out in 2010, and they're updated periodically. CDC actually has a great contraception app where you can access these eligibility criteria methods from your phone. And they break down the recommendations into 4 categories. A Category 1 method can be used without restriction. In a Category 2 method, the advantages of that method usually outweigh the theoretical or proven risks. With Category 3, the method is usually not recommended unless other more appropriate methods are not available or acceptable. And then with Category 4, that method is absolutely contraindicated and should not be used. For IUDs, there are very few Category 4 contraindications, and they're listed here on this slide. Pregnancy, puerperal sepsis, so that's sepsis related to childbirth, immediate post-septic abortion, unexplained vaginal bleeding, uterine fibroids that interfere with placement, and I think that's an important distinction here. Uterine fibroids in and of themselves are not an absolute contraindication to IUC use. It's only ones that would interfere with your ability to place the IUD. Uterine distortion that's congenital or acquired, so that would be things like a septum, didelphys uterus, etc. An active purulent cervicitis, or PID, so this is untreated. And breast cancer within the last 5 years is an absolute contraindication to hormonal IUDs. So definitely there are some contraindications, but they're very few overall. All right, so the one key question, so this is another thing that hopefully many of you in the audience are familiar with, but those of you who aren't, this is a really great tool that you can take into your counseling sessions with your patients. And it's a really simple but quite brilliant concept. It's just the idea that there's one key question that every woman of reproductive age should be asked every year by her healthcare providers, and not just her women's health providers, but even primary care doctors, specialists, etc. Would you like to become pregnant in the next year? And that question can really be the basis for a lot of counseling that you would do with your patients in terms of determining, does she need a contraceptive method? What's the right contraceptive method for her? Do we need to discuss preconception counseling? Are there other medical issues that might need to be addressed before becoming pregnant, etc.? And so I would encourage all of you, if you don't already do this, to adopt this question into your patient screening and interviews, because the answers can really help guide how you counsel and treat your patients. All right, and we talked a little bit about Lark continuation rates earlier. And understandably, the Lark continuation rates are really the highest out of all reversible methods. So we talked about 3-year continuation rates earlier. These are 1-year continuation rates, higher than they are at 3 years. So 78 to 84% for the Lark methods. Oral contraceptives a little bit lower at 70%. And Depo and condoms have 1-year continuation rates of about 50%, so much lower again overall than the reversible methods. When you compare effectiveness of the different methods, this is a really helpful chart that you can use in your counseling with patients. So this is a tiered effectiveness chart showing at the top level the most effective methods of contraception, in the middle tier the intermediate methods, and then at the bottom the least effective methods of contraception. So the top tier methods are also called forgettable methods of contraception because it's not a method that relies on the woman having to remember to take it every day or get her refills or come back for her injection, etc. And these are methods that are more than 99% effective. The middle tier methods are less effective because they do require more vigilance and action on the part of the woman. And then the less effective methods tend to be the methods that need to be used every time you have sex. So this is a really great chart that can be very helpful to be used in conjunction with contraceptive counseling. On the next slide, this is a different version of that same chart, and this is a version that was put out by Bedsider. You can see this one's a little bit brighter, a little bit more colorful, and same basic concept, 3 tiers. Top tier are the most effective, middle tier are intermediate, and the bottom tier are less effective. What I really like about the Bedsider chart is the little pictograms that they have on the side. What is your chance of getting pregnant? And I think this is a really easy way for our patients to visualize what the pregnancy risk is, because it's one thing to say it's, you know, less than 1%, 6%, 20%, but to actually be able to see the diagrams and see the difference laid out there, I think it helps drive the point home a little bit more and makes it easier to understand. And they also tell you at the bottom right-hand corner here that the risk of pregnancy without birth control is over 90 per 100 young women in a year. So these are all things that you can help adopt into your private practice to help with counseling women. Some other things, other tools when you're counseling patients. The really good counseling is the most important part of the healthcare that we provide our patients, and is a really important factor in ensuring satisfaction and continuation with methods. So this comes from the Quality for Family Planning, which they've identified 5 key principles that should be used in quality counseling. And the goal is to help patients make informed decisions about their contraception. So first, it's establishing, maintaining rapport with the client. So that's, going into the room, greeting the client, finding out a little bit about her personal history, finding out a little bit about her as a person. Next, you assess the client's needs. Why is she there to see you today? This is a great point to incorporate the one key question. What are her reproductive health plans for the future? What's important to her about her contraceptive methods? What has she been on in the past? How has she felt about those methods? From there, the next two steps sort of work together. So step 3, work with the client interactively to establish a plan. So use that information that you got from your client assessment to talk about the methods that you think might be good for her, get her feedback, provide her with information and educational materials. Really important that they're things that can be easily understood and retained by her. Once you've picked that method, you're going to confirm her understanding of the method and address any questions that she might have. And I think it's really important when you're providing your educational material and confirming the understanding that you talk about effectiveness, side effects, and reasons that you would want her to return to the clinic, because again, those are all factors that can impact continuation and satisfaction with methods. So once you've done your counseling, you can try and use the teach-back method to confirm that the patient has understood how to use the method, what's expected, etc. And so what the teach-back method does is it has you ask the client specific questions that verify the information's been retained. So you could ask questions about the benefits, and they're pretty simple questions. Tell me about some of the benefits of this method, or how do you think this method is going to have a positive impact for you? For the side effects, it can be as simple as just asking her to tell you the 3 most common normal side effects women have when they start this method. So if it was an IUD that you were talking about, that could be some irregular bleeding and some cramping. And then also saying, so if you experience cramps, what would you use? What would your plan be if that happened? And then finally confirming follow-up. What would be abnormal symptoms with this method? Tell me what you'll do if you experience spotting that's bothering you. And encourage the patient to return to your clinic or to contact you if they're having any issues with any of those methods. So usually when I'm reviewing side effects with patients on a method, I tell them, say for example, they're starting the levonorgestrel IUD. I'll say it's normal to experience some irregular bleeding for the first 3 to 6 months. That should get better over time. If you're having any issues, we'll talk about things that they can do to manage it. But please come back and see me. Sometimes there's things that we can do to help manage that irregular bleeding. That doesn't mean taking the IUD out. And so by setting them up to encourage them to come back, and also to encourage them, to reassure them that the experiences that they might have are in fact a normal part of the IUD and not to be thought of as necessarily pathology. Okay. All right. So now we're sort of going to leave the counseling behind and readdress the issue of PID and infertility. And again, we're sort of beating a dead horse here, but I think this is probably one of the most persistent myths about IUDs. And that's a myth that exists not just among patients, but also among providers, and a really important one to address. So again, PID incidence among IUC users is pretty similar to that among the general population. It's really the pre-existing sexually transmitted infection at the time of insertion, not the IUD itself, that increases the risk of PID. So we know that there is a slightly higher risk of PID within the first month after insertion. And again, vast majority of time that's usually due to a pre-existing sexually transmitted infection. So really important that people are screened appropriately at the time or prior to IUD insertion. And it is considered safe to screen on the day of insertion and treat if that result comes back positive. You do not have to delay insertion to pending the results of the sexually transmitted infection test. Similarly, it's the myths about IUDs and infertility are actually based on some data based on older IUDs that are no longer available in the market. So there was the thought that, based on that old data, that the presence of an IUD resulted in infertility based on PID risk that resulted in tubal occlusion. But there have been some good studies with modern IUDs that have shown it wasn't the presence of the IUD itself that increased the risk of infertility. It was the presence of a chlamydial infection. So again, you can provide your patients with reassurance that by choosing the IUD for contraception, they are not risking their future fertility. All right, so we're going to move on to another case presentation. So here you have Claire, she's 38, G3P2. She had a miscarriage about 2 weeks ago. She was on the pill before her miscarriage, but got pregnant because she couldn't keep up with her refills. And right now she wants to wait about a year before getting pregnant again. She does have a history of a low-grade PAP. Her BP today is 165/100, and she does report occasional migraines. So just like the last case, start thinking about what would you do in your clinic, and what do you think the main issues are here. So let's go on to the third poll. What would you rule out a Lark method for Claire because of her migraines? So we'll go ahead and get that started. All right, so we have 7% said yes, you would rule out a Lark method, 82% no, and 11% said not sure. So again, the majority rules here, so 82% of you were correct that a Lark method is not out of the question for Claire because of her migraines. And we're going to move on to talk about some of the medical comorbidities and risk factors for complications. All right, so some of the issues here that we're going to address in the next slides: her blood pressure, recent miscarriage, desire to get pregnant again, concerns about compliance, and PAP results, as well as history of migraines. So, can a woman use the Lark method if she has high blood pressure? The answer to that is yes. Lark is safe even for uncontrolled hypertension. So here we have the CDC medical eligibility criteria, going back to that, showing the criteria for the different Lark methods with hypertension. So you can see that they are category 1 pretty much across the board, except for women who have significant elevated systolic and diastolic blood pressures or who have vascular disease. But even in those situations, the levonorgestrel IUD and the implant remain a category 2, which is where benefits outweigh risks. And I think whenever you're thinking about comorbidities and contraception, it's really important to balance that against the risk of an unplanned pregnancy in a woman with that condition. And so in this situation, there's no contraindication to IUD use. How about migraine headaches? So for migraines, without aura at age less than 35, category 1 for copper IUD and 2 for the levonorgestrel IUD or implant. Without aura over 35, no change, and with aura, any age, there's no change in the medical eligibility criteria. So very safe and to be used in this population. And you want to compare that to the pill. For a woman with aura, it is an absolute contraindication. And so these are really great options to offer to these women who aren't eligible for combined hormonal contraceptives. For other conditions, for endometriosis, levonorgestrel IUS is a category 1. Category 2 for a copper IUD. Personally, in clinical scenarios, I've had a lot of great success in treating women with endometriosis with the levonorgestrel IUD. It really works very well for a lot of those patients in managing their symptoms, although sometimes the insertions can be a little bit more uncomfortable for them. The trade-off in the longer-term use has been really great. Obesity is not a contraindication. And then again, as we reviewed earlier, the uterine fibroids are not a contraindication as long as you're still able to insert the IUD itself. Some other conditions that you might run into in your clinical practice for HIV infection. If they're HIV positive or high risk, it is category 2. For women who have AIDS, it is a category 3 for both methods. PID, again, should be familiar to you by all that. Any past history of PID is not a contraindication. It's only a current and treated PID that would be a contraindication to use. And with STIs, vaginitis or increased risk of STI is category 2. For very high risk of STI, they do rate it as a category 3 here. That's a little bit of an ambiguous characterization. You know, what does very high risk of STI mean? I'm going to direct back to the CHOICE study, which is that study of over 9,000 women. That was a population who had a baseline history of STI of 40%. So 40% of women who enrolled in the trial had a history of an STI, which some might consider very high risk. But the rate of PID in that population in that study was very low. So I think this is a, it's a category 3, so it's not an absolute contraindication. This is where risks may outweigh benefits, and I think it's important to have a very careful discussion with these populations. You would obviously want to screen them for STIs and then individualize the decision for these women and determine if it's the best method for them. And then for current gonorrhea, chlamydia, or cervicitis, it is a category 4, so you would want to treat those patients first. And here we have the eligibility criteria for a variety of other conditions, and we've got the CHCs added into this chart for a comparison. So again, if you look at the first 2 columns, copper IUD and levonorgestrel IUS, compared to CHCs in the far column, you can see we don't see any category 4s for the IUDs, but you see quite a lot of 3s and 4s for the combined hormonal contraceptives. And again, all this data is available online. And I think we're running a little bit over, but we're ready for the Q&A part. So any questions, feel free to go ahead.
Thanks, Amna, for this excellent presentation. As you mentioned, at this point, we're opening the floor for questions. To ask a question, please enter it into the question box on your control panel.
So we do have one question up so far from Asma. What is the ideal contraceptive for a mentally challenged female? That is a very complex question and doesn't really have a very straightforward answer. That is really the, there are so many factors that go into the contraceptive decision-making process with those patients that I would be remiss in giving you a method over, in this situation. So I really think when you're dealing with those situations, it's really important to engage the caregivers, talk about what's going on in that particular situation, and engage the patient as much as you're able to. Again, there's so much variation in severity of disease that it's really just hard to make a recommendation, but you're really going to have to take a much broader approach when you're doing your counseling, and really carefully discussing the method of use and side effects is going to be very, very important. Okay, so we've got a couple other questions here. There was a question from Catherine about the release of hormones on the IUD. There's a reservoir in the body of the T that has a membrane that has a slow release of hormone from the reservoir out into the uterus. Another question from Catherine about a woman with a bicornuate uterus. Is she a candidate for an IUC? That, unfortunately, she would not be a candidate for an IUC. A bicornuate uterus is a contraindication to IUC insertion, and for a patient like that, if they were interested in a Lark method, I would recommend the subdermal implant for them in that situation. All right, this is a great question from Sally about if you insert an IUD and on follow-up you don't see the string. Ultrasound shows IUD in place and string and cervical canal. Should IUD be taken out at that time, or wait until it's due to come out? That's a really great question. That's something that I see all the time. If the IUD is properly positioned, even if you cannot see the strings, as long as she's happy with the method, you can continue it until it's due to come out. So again, as long as the IUD is properly positioned with no issues, just leave it in there. When it is due to come out, it can make removal slightly more difficult, in which case if you don't have experience removing IUDs with no strings available, then certainly seek out a referral. That's unfortunately not in the scope of this talk to go over strategies for that, but it's usually pretty straightforward. Let's see. With the decrease in levonorgestrel dosage over time in both the Mirena and the Liletta, is there a decrease in effectiveness over time? This is from Linda. There is no decrease in effectiveness for the duration that it has been approved for. So over the 5 years, there is no decrease in effectiveness. It's considered to maintain that effectiveness for that full 5 years. There's more interest now in use of the levonorgestrel IUD beyond the 5-year approval time, and there's a couple of studies that have looked at 7-year use, and there is data to suggest that it does maintain its effectiveness through 7 years. Okay. Another question from Rana, why do you think Lark uptake has been slow in the US when compared to the other parts of the world? That's a really great question. I think the IUD history in the US is a lot more fraught than it is in other parts of the world. I think the legacy of the Dalkon Shield, which was here in the US in the primarily 1970s, was taken off the market in the early 80s, really left a big stain on Lark use and really dissuaded a whole generation of women essentially from using IUDs for contraception. And that legacy is slowly starting to go away, but I think, you know, it still persists in certain areas, and I think we have a lot of really great scientific data to support the efficacy and safety of the IUDs, and I think we're seeing the tide turning as more and more physicians and clinicians become comfortable with using it and recommending it. But unfortunately, there is still work to be done, whereas in other parts of the world, in Europe and Asia, the Dalkon Shield didn't have quite the same effect that it did, and there weren't the same issues that we had here in the U.S. And so it never really ran into that huge roadblock where the IUD has always just been sort of around and available, and so it's just been widely used. And they also have better healthcare that actually funds IUD use, which is another big barrier to use. Let's see. Another great question here from Jacqueline. Should everyone be tested for STI before insertion of IUD? No, not everyone needs to be tested. We recommend using a risk-based screening algorithm. And so that risk-based screening looks at a few different factors that are really easily assessed. And this is a great study, a great paper that came out of the Choice Project again, where they looked at different criteria. And they found that asking questions, so number one, age less than 26, history of inconsistent condom use, history of any STI in the past, and multiple sexual partners. If they answer yes to any of those questions, then you should screen those patients for a sexually transmitted infection. And that was found, using those criteria, was found to have over 99% sensitivity for picking up a sexually transmitted infection. So really a pretty basic, really simple set of questions to ask your clients before. And we're running a little over on time, so I'm going to stop with this question. Please discuss the need for women to check their IUD strings. That's a great question. The checking IUD strings used to be considered something that women were supposed to do every month after their menstrual cycle. Check the strings to make sure the IUD is still in position. That's not something that we recommend anymore. Again, checking the strings is really making sure that there was no expulsion of the IUD. Now, we know that the risk of expulsion is highest in the first 3 months after insertion, and it does go down after that. So certainly there's no need to have women come back to the clinic for an IUD string check the month after insertion or 2 months after insertion. Usually what I tell my patients to do is I instruct them on how to check their strings. I do offer them to return for a string check if they ever can't feel their own strings. And I suggest that they can do it periodically for the first 3 months. If they ever can't feel their strings, they can come back and see us, and we will check for position. But that otherwise there's no indication for them to check the strings as long as they're not having any issues, and then it would be checked just at their normal yearly well woman exam. And I think we'll go ahead and stop with the questions there again, since we are starting to run over a little bit.
Thanks, Amna. We really appreciate that.
Great. And so here's just a little summary slide for y'all to read over. I won't reiterate all the information that's on here, but basic take-home point is that IUDs are safe and effective for almost all women, and it's important to understand the side effects and to counsel and discuss that with your patients before you insert them. And then here's some resources. That's not advancing. There we go. So some resources for y'all to check out for more information on IUDs and Lark methods. Thank you.
Thanks again, Amna. We really appreciate your thoughtful presentation, the concern you have for patient-centered care. This was really informative. And we'd like to thank all our participants for joining us today and for submitting such great questions. In just a moment, I'll tell you how to collect your certificate. But first, I'd like to direct you to our upcoming webinars. We hope that you'll save these dates. On May 24th, we have part 2 of this session, which is going to discuss pain management strategies and follow-up for IUC users and proper insertion techniques. So this looks to be a very interesting session. If you'd like to check out more of ARHP's educational resources, we hope that you'll visit our website at www.arhp.org. All of these resources, including today's webinar, are brought to you free of charge. Please help us keep these resources open access by becoming a member of ARHP today. And now, to the PostTest survey. You will receive an email from GoToWebinar 1 hour after this session ends, containing a link to the PostTest survey. After completing the survey, you'll be able to print your continuing education certificate. Please be sure to print before closing the window. Sometimes it'll disappear. Please be sure to print before closing the window. If you have difficulties printing or retrieving your certificate, please don't hesitate to contact us at education@arhp.org. Thank you again for joining us today. We hope that you will take part in other live and on-demand sessions hosted by ARHP.